lymphoma. Lymphoma, if it's in the lymph node, lymphoma. Now watch how easy this is. If it's a lymphoma, there's only two choices. It's either Hodgkin's or it could be one of the many non-Hodgkin's. So what's the difference? What does the board have to give me if they want me to say it's Hodgkin's? What do they got to give me? They got to give me a very special cell. Does anybody remember what that cell was? They got to give me the Reed-Sternberg cell. You want me to pick it, you got to give me the RS, the Reed-Sternberg cell. You give me Reed-Sternberg cell, Hodgkin's. If there's no Reed-Sternberg cell, then it's non-Hodgkin's. It's that simple. It's that simple. All right, now how do you diagnose lymphomas? Well, guess what? They're in the lymph node. So my best test will always be a lymph node biopsy. Lymph node biopsy. Makes sense. Lymphomas in the lymph node. Let's do a lymph node biopsy. That's how you'll diagnose it. Now, leukemia is in the blood. So what's the first test I'm going to do to check the blood? Everybody gets a CBC and a peripheral smear. So over here, the first test will be a CBC with peripheral blood smear. Now, the best test will be to look in the bone marrow. So the second or confirmatory test would be the bone marrow biopsy. Got it? Makes sense. It's in the blood and bone marrow. You check the blood, you check the bone marrow. Got it. Okay, very good. We're getting this down. Now, for leukemias, again, we have two choices. It's either acute leukemias, which come quick and kill you quick, or it's chronic leukemias, which come slow and kill you slow. Now, if you want me to pick acute leukemia, what is in the blood and bone marrow? Well, if it's acute, there's something special. What am I looking for? Immature cells called blasts. There you go. Blasts. You bet. Blasts. So here's the key. If you want me to pick it, you gotta give me blasts. Not just one, lots of them. Listen, these are killing you. They're gonna kill your marrow and you're gonna die of bone marrow failure. So acute leukemias are dangerous because the bone marrow fails. The bone marrow fails. You're gonna die of bone marrow failure. Treat it early, treat it aggressive, or you will be dead usually within a year of bone marrow failure because blasts just fill everything up. They fill it up. Now for chronic, I'm gonna see cells, but not really blasts. I'm gonna see mature cells. Mature cells. They look like normal. They're acting kind of normal. So they kill you slow. They kill you slow because they're still kind of acting normal. They kill you slow. Comes on slow. That's why they call it a chronic disease. Comes on slow and kills you slow. Killing you slowly with mature cells. Killing you slowly with mature cells. Tearing your heart out. All right, I'll stop singing. The sad thing is, even when I have my voice, it doesn't sound any better. Even when I have my voice, I still can't sing. All right, so it kills you slow. You see, there's a big difference here. Big difference. If I see blasts, they kill you fast from bone marrow failure. If I see mature cells, it kills you slowly because they're kind of acting normal. Now, again, I got a 50-50 shot of getting it right. If it's acute, there's two big categories for acute leukemia. You got acute lymphocytic, which you'll see blasts, usually in children. So I remember all my children, most common age 3 to 7 years old. Or it could be acute myelogenous leukemia. Acute myelogenous leukemia. Now this usually occurs in adults, usually 15 to 40. Any age, but 15 to 40 most common. Okay, so again, when it's blast, it's acute. Two answers. So it's either AML, usually all my children, or it's, let's see, ALL, all my children, or AML, which is adults in their midlife. Adults midlife, acute midlife. Works good. All right, Nice and easy. Now, what about chronic? Well, for chronic, I got three big ones, three big chronic ones. Again, I'm going to have chronic lymphocytic leukemia. What's good about that one is it's old people. It's usually around 60. So they're going to have too many lymphocytes. They look mature. They look normal. They look like normal cells. Just too many of them. And you'd be in the 60s. Now, what about CML? Well, again, I'm going to see too many myeloid cells like neutrophils, basophils, eosinophils, too many myeloid cells. And they're usually midlife, 30 to 60. 30 to 60. Midlife. And then finally, there's one more. What if I see lymphocytes, but they're hairy? Well, that would be awesome because then the answer would be hairy cell leukemia. Hairy cell leukemia, I'd love it. Hairy cell. That one's kind of a giveaway. Hairy cell leukemia. Now, this one again is 30 to 60, but it's men much more than women. Men are hairier than women, that's for sure. So it's again 30 to 60, but usually men. Hairy men. Middle-aged, hairy men. That's hairy cell leukemia. Okay? So now we can go through the notes, but you have the big picture here. If you're worried about a leukemia, you check the blood with a CBC and a blood smear, then you confirm it with the bone marrow. If you see a blast, it's acute. Blasts are acute. Blasts are acute. If it's in a child, it's probably acute lymphoblast. If it's an adult, it's probably acute myeloblast. Now, if I see too many mature cells, then I'm going to say it's a chronic leukemia. It's going to come on slowly, gradual onset. Again, if it's an old person, too many lymphocytes, I'll think about CLL. If it's in middle age with too many myeloid, I'll say CML. And then if it's middle age with hairy lymphocytes, I'm going to say that's a hairy dude. Okay? Now, over here, when it's lymphoma, you're going to biopsy the node, not a needle. No, take the node out. Take it out. Take the node out, and you'll see the tumor. If there's Reed-Sternberg cells, Hodgkin's, no Reed-Sternberg cells, it's one of the many non-Hodgkin's. This is the big picture. You get this in your brain, and you'll know where to go. Okay, so let's go through these. I'm going to start it with leukemias. Again, blood and bone marrow. We're going to start it with acute. They kill you fast. Remember, they kill you from marrow failure. So your red cells are low, your white cells are low, your platelets low. Everything's low. But they've been replaced by blasts. They're replaced by the blast. The blast crowd them out. Okay? All right, now let's go through some of our notes now. Got the big picture. It's notes time. We're off to a racing start here. I'm excited. I love this day. This is a fun day. All right, now the definition of acute leukemia is, as I mentioned, it's acute, it's rapid, it comes on fast and it kills you fast. So that's why they call it acute. Rapid onset of bone marrow failure. The blast kill the marrow. They kill it. So this is basically a relentless destruction of the normal cells. They're all killed. Yeah. Why? Because these blasts are not maturing. They just divide and divide. They don't ever mature. They crowd out the normal cells. So these blast cells lose the ability to mature and function normally. They're just blasts. All they know how to do is proliferate. All right, now we don't know the cause of most cases, but on the exam, there are some things you should look for, some known associations. For instance, radiation, atomic bombs, Hiroshima, Nagasaki. If you survive the atomic bomb, you're at high risk for leukemias, especially AML. Benzene in cigarette smoke, in industry. If you get exposed to a lot of benzene, you're at risk for AML. And again, most of these are for AML. If you're exposed to chemo agents, a problem with chemo agents is chemos kill tumors, but they also induce mutations. So you could get what's called a treatment-induced malignancy. So again, AML can arise from somebody who had melphalan or etoposide or basically any alkylating agent. Any alkylating agent can wind up with acute leukemia. And then some leukemias and lymphomas are associated with viruses, okay? Like for instance, retroviruses like HTLV1, HTLV1, there we go. This is association with something called adult T cell, retrovirus like T cells, leukemia / lymphoma. Adult T-cell leukemia/lymphoma. It's a very aggressive leukemia. Lymphoma, it's kind of a cross between the two. HTLV1. So some of these have been associated with viruses. All right, now let's talk about this. Acute leukemia has been associated with genetic things. For instance, Down syndrome gets acute leukemia. Now, if they're a child, you think about acute lymphocytic leukemia. But on the other hand, if the Downs is a baby, Downs babies, they usually get AML. Interesting. So it really depends on what age they are. So Downs as a child, think all my children. Downs as a baby, they usually get AML, a little bit more aggressive. It's also associated with a higher incidence in Klinefelter syndrome and clearly myelodysplasia. This is a pre-leukemic syndrome. Pre-leukemic. Now, let me give you the definition. To say there's acute leukemia, you got to do the bone marrow. Bone marrow. By definition, acute leukemia has greater than 20% blasts. That's the definition of acute leukemia. 20% of the cells or more are blasts. So what if I tell you, I do a bone marrow and there's 15% blasts? Well, that's not enough for acute leukemia. So we call it myelodysplasia. Myelodysplasia has blasts, but less than 20%. Got it? So it's to get over 20%, now it's acute leukemia. So this is a precursor for developing acute leukemia. Make sense? The definition is, you got blasts, but less than 20%, that's myelodysplasia. All right, now how does acute leukemias present? Well, since they kill out, they crush out the normal cells, you're going to present with the symptoms of a pancytopenia. Now, I need to know, why might the white count be normal? What is it? Pancytopenia means the red cells are low, the white cells are low, the platelets are low. Why is the white count normal? Explain that to me. How can the white count be normal if the red cells are low, the platelets are low, all the cells are low? Excellent. Avni, excellent. The blast cells took over. So the normal red cells are low, the normal platelets are low, the normal white cells are low. What's replaced them? Blasts. So the white count's up, but it's all blast. So you got a pancytopenia, all the normal cells are down, but the white count can be elevated because those are the blasts. Now, 3 things. Number 1, you're going to have anemia because the red cells get killed. And that's the most common presenting symptom. You're tired, you're fatigued. Doc, I don't feel good, I look pale. I get a CBC, and sure enough, the H is low, but the white count is up with blasts. See, the CBC is the first test, and you're going to find the blasts. Now, you can also present with bleeding because of the platelets. You kill mama megakaryocyte, no more megakaryocytes, no more platelets. You present with bleeding. You can present with infection because the normal white cells are destroyed. Listen, blasts are not going to protect you. Blasts are not mature. You need mature white cells to prevent infections. All right, now the 2 major types is we got acute lymphocytic, as I mentioned, all my children, and we got acute myelogenous, more common in midlife adults. Clinically, though, they present the same way. They both present with a rapid onset of pancytopenia, both of them, indistinguishable. All right, now in addition, the blast can go into the liver, the spleen, and the lymph nodes, and also the bone. You get some bone pain as well. So it's mostly in the blood and marrow, but it can go into other areas as well. Now, some very important associations. AML-M3. AML-M3 is the promyelocytic leukemia. This one often gets DIC. M3 DIC, M3 DIC, M3 DIC. And DIC, disseminated intravascular coagulopathy, can kill you. Very dangerous disorder. So M3, remember DIC. Now, CNS involvement. If the blasts go into your brain, it can look like meningitis. That's present at about 5% of patients at the time of diagnosis. Now, that's important because if it's in the CNS, chemo can't get there. Chemo can't get there normally. So we're going to have to do intrathecal chemo. You're going to have to put the chemo into the CSF if the CNS is involved. Okay, so very important to check the brain. If the CSF is involved, we'll have to treat that too. All right, now when does CNS usually get involved? Well, usually AML, M4, and M5. These are the monocytic forms of AML. They like to go in the brain. They also like to go in your skin. So I put that here. So CNS involvement, skin involvement. We call it a chloroma. You'll see a yellow mass in the skin. Let me type this because this is going to take me forever to write with my finger. So it goes in the skin. We call it a chloroma. Oops, I put too many capitals. Chloroma. And it can go into your gingiva, giving you gingival hyperplasia. So that's what's unique about M4 and M5. What's unique about them is they like to go into your skin, they like to go into your brain, and they like to go in your gingiva. Now they also have a special marker. For M4 and M5, they have a marker that's very important. It's called esterase. So esterase positivity. So esterase positive, that is AML, M4, and M5. Those are the ones that have esterase. All right, now here's an important term, leukostasis. Leuko means white cell, stasis means blood's not flowing. If you have a tremendous amount of blood cells, a lot of tumor cells, they're going to get sticky, hyperviscosity, blood's not going to flow. That's leukostasis, when you have really high white counts, extremely high. This is going to cause sludging of the leukemic cells in the blood, and it's usually going to be in your brain. So headache, confusion, blurring of vision, it looks a lot like a stroke. It can also get stuck in your lungs. You get shortness of breath, you can't breathe, and finally, it can get stuck in your male brain. If it gets stuck in your penis, you get what's called priapism. This is not good. I don't want things stuck there. I don't want it stuck in my brain. I don't want it stuck in my lungs. We're gonna have to do something special. Question, can anybody tell me, how could I get the white count down very rapidly? Chemo takes time. How can I get it down right away? What might I do to get rid of these white cells? Leukapheresis. Hook them up to a pheresis machine, spin their blood, throw the white cells out. So this is kind of like an emergency. If you're getting stroke symptoms, stroking your penis, oh, that's not good, stroking your brain, stroking your lungs are getting infarcted, you got to do something special. You got to do leukapheresis. Very important. Now you can also use hydroxyurea, but usually leukapheresis is very fast, very quick way to get it out. All right, good. They love special scenarios. All right, now your first clue was the CBC. Anybody comes in with anemia or bleeding or infection, you're going to get a CBC. And that's going to show me the white count is elevated. Typically, it's usually white cell elevation, usually because of the blast. Now, how do I know this blast? I'm going to get the differential. When the white count's up, I want to know which white cell. So you're going to get the differential count. And it will count how many neutrophils, how many basophils, how many eosinophils, how many lymphocytes, and how many blasts. You shouldn't see any blasts. They can have a lot of blasts. So the CBC really helps you pick it up. Now, what are you going to see with the normal cells? They're usually decreased. All the normal cells are decreased on presentation. So pancytopenia. Now, the white count is usually elevated because of a lot of blasts. But sometimes the blasts pack the marrow and they don't leave. So if the blasts don't want to leave, they stay in the marrow, you might have a low white count as well. Okay, but most cases on the exam are going to be an elevated white count because the blasts love to go into the blood. As we talked about earlier, thrombocytopenia, anemia, very common presenting findings. All right, now are there any other disease that give you pancytopenia? Heck yeah. Anything that damages the marrow. Anything that damages the marrow. Aplastic anemia gives you pancytopenia. Bone marrow infections like parvovirus B19, a metastatic cancer, B12 deficiency, lupus, Big spleens can eat your blood, give you pancytopenia. Myelofibrosis. But none of these is gonna have blasts. None of them. So many things give me pancytopenia, but once I see the blasts, I'll know it's acute leukemia. I say blasts, you say acute leukemia. It's that simple. All right, now to prove it, I'm gonna have to do the bone marrow. Do the bone marrow, and remember the definition, greater than 20% of the blasts, greater than 20% of the cells are blasts, that confirms acute leukemia. Okay, so this is my most accurate diagnostic test, bone marrow biopsy. You see all the blasts. And here's what they look like. Look at the size of these cells. Compared to a red cell, they're huge. You can put 1, 2, 3, 3 of these would fit in this guy. He's a monster. He's huge. He's much bigger than all the other cells. Same for this, huge, huge, really big. Now they often have a clear space right here. I don't know if you can see it. There's a clear space right there. That is called a nucleolus. That's a nucleolus because these cells are immature. They're proliferating. They have nucleoli very commonly. All right, now looking at blasts by themselves, not good enough. I need to characterize them. I got to do stains. I got to do flow cytometry. I got to find out, is this a lymphoblast? Is it ALL? Or is it a myeloblast? Is it AML? I got to figure it out. So let's talk about that. If it's AML, one clue they like to give is our rods. Now it's kind of hard to see, but there's this red rod in here. Oh boy, red rod right in there. Yeah, it's really hard to see. Red rod. So you'll see these red rods. Let me draw it for you. Here's the blast. Notice it's mostly nucleus. Huge nucleus. They often have a nucleoli. So if you look at this blast right there, there's the nucleolus. See it? Big old nucleolus. Then in the cytoplasm, you'll see this red rod. This red rod, we call it an our rod. Now these are most common, not just in AML, but AML, M3. And they're going to trigger the DIC. So M3 has the most rods. M3 is most likely to get DIC. Okay, very important to recognize that. Now, if there's no our rods, well, then I can stain it for myeloperoxidase. Makes sense. Myeloid, myeloperoxidase. Now, if the esterase is positive, that's the monocytic form. That's either M4 or M5. M4, M5. That's the one that likes to leave the blood and go into your brain, your skin, your gingiva. Okay? Our rods can be seen in other types, but M3 has the most. M3 has the most. So I've seen it in other forms too, but for an exam, you see our rods, favor M3 as the most likely answer. But you could see it in other types too. It's just most common in M3. All right. Oops. Hold on. There we go. AML. Now what about ALL? What about lymphoblasts? Well, they don't have myeloperoxidase. They don't have esterase. What does ALL have? Well, they got common ALL antigen, CALA. Now, this has a CD number. This is called CD10. CD10. Now, what I want you to know about this is it's a good marker for ALL, and it has a good prognostic feature. Good prognostic feature. So if you see CALA, that's usually a good finding. Now, if you remember back to immunology in step 1, what was a marker of an immature lymphoblast? TDT. This is a marker of immature lymphoblasts, TDT. So great marker. Now, how do I remember it? Because this is the big one they like in exam, TDT. I remember because of TNT. What does TNT do? TNT is for blasting things. TNT. So TDT is for blasts, but they're for lymphoblasts. Lymphoblasts. Okay, got it? So notice these markers are different. For AML, we look for our rods, especially for M3. We look for myeloperoxidase. We look for esterase for the monocytic forms. For ALL, we're looking for TDT. And then if they have common ALL antigen, That's a good prognosis. This is CD10. That's good if they have that. So different markers here. All right, now all of these acute leukemias are going to have a high rate of cell turnover because blasts are dividing very quickly. When cells divide and die, well, they're going to produce a lot of LDH. The higher this is, the faster the tumor is growing. And of course, when cells die, the nuclei broke down to uric acid, so you're at risk for hyperuricemia and gout. Now, flow cytometry, very helpful for looking for CD numbers. So I can tell, is this a B lymphocyte? Is it a T lymphocyte? I can try to tell what kind of blast it is. Okay, so most accurate test is doing flow cytometry. Look for CD10, look for the other CD numbers. Flow cytometry, very helpful for distinguishing B cell, T cell, telling you what kind of blast these are. All right, now let's get to treatment. We got the diagnosis, now we got to treat. Good news is blasts divide quick, so they respond well to chemo. So here's the gold standard. We want to get you into remission. If I get you into remission, then I will do consolidation to try to maintain the remission. If you go more than 5 years, you're cured. So get you into remission, then consolidate you, and then hopefully it doesn't come back. If it does come back, we'll have to do a bone marrow. Okay, so here we go. Chemotherapy is done to induce remission. Now, what the heck is remission? Remission means after the chemo, I can't find the tumor. It's virtually gone. See that? The blasts are gone. They're gone. Can't find it. Then the normal cells start coming back. That's remission. Your normal cells come back. The blasts are gone. Can't find them. That's good. That was good. Then we're going to give you another couple rounds of chemo called consolidation. Because just because I can't find them, there may be 1 or 2 clones. So we're going to do consolidation, which is more chemo to try to make sure you got everything. Now again, if you finish these 2 and I can't find the tumor, well, after 5 years, no tumors come back, you're cured. If the tumor does come back, that means it's relapsing, it's coming back after your treatment. Now we got to do a bone marrow transplant. We got to kill your entire marrow. Kill everything and get your new marrow. Okay? Natasha wants me to repeat it. Here is your treatment algorithm for all of the acute leukemias. We're going to blast you with chemo to kill all the blasts. We're going to kill them. So that's called remission. You give them so much chemo that after the chemo, I can't find the tumor. It's gone. I look in the blood, can't find it. Look in the marrow, can't find it. Great, you're in remission. Now there may be 1 clone or 2 that you couldn't see, but they're still there. So we'll continue to give you other rounds of chemo called consolidation to try to kill any clones that are left. So if I put you in remission, then I consolidate you. After that's done, if the tumor never comes back, you're cured. If the tumor comes back, that's called a relapse. Now you got to get a bone marrow transplant. Not cool. Bone marrows, you don't want to do bone marrows. You could die from the bone marrow. All right, now, how do I induce the remission? How do I get you into remission? Well, the initial chemo depends on the type of leukemia it is. For AML, you should know that you're going to give 2 different types of drugs. You're going to give cytosine, arabinodase, I'm tripping over my tongue today. Ara-C for short. Let's just use Ara-C. And then we're either going to give one of the rubicin drugs, either daunorubicin or idarubicin. So basically 2 drugs to get you into remission. Now for ALL, going to use 3 drugs. 3 drugs for ALL, and they're different drugs. Okay, so again, a rubicin drug, but now we're going to add vincristine and prednisone. Now, can anybody tell me the toxicity of rubicin drugs? Doxorubicin, daunorubicin, idarubicin, cardiotoxicity. Can anybody tell me the classic toxicity of vincristine? Vincristine? Neuropathy. neuropathy. Good. And of course, prednisone is Cushing's, right? Cushing-like symptoms. Good. So this is called your induction therapy to get you into remission. And that's what you need to know. Initial treatment for both. All right, now some special changes. This is very testable. So I gave you the general rule. Now here's some special things. If it's promyelocytic leukemia, which is AML M3, well, for that one, we're going to add all trans retinoic acid. Yeah, because this one will respond because it has translocation 15, 17. Translocation 15, 17. 17 is your vitamin A receptor. So this translocation knocks out one of your vitamin A receptors. So to overcome this blockage, we're going to give you massive all-trans-retinoic acid to try to mature the cells. Okay, so only for M3, in addition to the chemo, we're going to add all-trans-retinoic acid. So let me go back. We're going to give you this chemo for AML, Ara-C and daunorubicin, and then we're going to add all-trans-retinoic acid only for the M3 one, the one with the hour rods. Got it? Only for M3. All right, now some other special treatments. If there's a really high white count, well, then we'll do leukapheresis to prevent the leukostasis. You don't want a stroke, right? Too many tumor cells, leukapherese them. That's what's really high count, you're getting symptoms. Now, very important, methotrexate must be given. Methotrexate is given for AML if they have meningitis findings, or they find the blast in the lumbar puncture. But you got to give it for all ALL, regardless of whether the LP is normal or not. So let's repeat. I will give it for AML if they have signs of meningitis, or if I see blasts on the LP. So positive lumbar puncture, we're going to give intrathecal methotrexate if the LP is positive. Now, if the lumbar puncture is negative for ALL, doesn't matter. All ALL is going to get methotrexate. All ALL gets methotrexate because ALL is notorious for recurring in the CNS. Notorious. Okay? So if the brain is involved, or for all ALL patients, you got to give intrathecal methotrexate. Okay? For all of the ALL patients. Good. All right, now acute, interesting, kills you quick, comes on quick, kills you quick. Chronic comes on slow and kills you slow. So let's talk about chronic myeloid leukemias. This is one of the myeloproliferative disorders. Now look at that name. Myelo means marrow, proliferation. So this is going to have a proliferation of the myeloid cells, which means mostly neutrophils, bands, neutrophils and bands. Can anybody tell me what that's called when you see a lot of neutrophils and bands? Does anybody know what the name for that is when you have a lot of neutrophils and immature neutrophils called bands? Yeah, it's a left shift. So it looks like a left shift. It looks a little like a bacterial infection. But it's also going to have basophils and eosinophils as well. Okay, so it's all the myeloid cells. But in addition, what else is proliferating? The red cells. So the red cell count may be up. What else is proliferating? Platelets. The platelet count is usually up as well. So let me repeat. Myeloproliferative syndrome means everything in the marrow is proliferating. Now for CML, it's mostly the myeloid cells, which are the neutrophils, bands, eosinophils, and basophils. But again, the red cell count will be up, and the platelet count will be up too. They're all going to be up. Okay, but again, it's mostly the granulated cells. All right, now the good news is these cells look normal, they look mature, and they retain most of their function. So this disease comes on slow and kills you slow because you got a lot of neutrophils, but they're still kind of working. You got a lot of basophils, they're still kind of working. These cells are still working. All right, now this is a tumor though. It is a clonal disorder. It's a tumor. So we're going to look for the diagnostic test, which is the Philadelphia chromosome. This is your gold standard. Look for the Philadelphia chromosome. This is very characteristic of the disease. We don't know why you get it, but we know it's a translocation. Translocation between chromosome 9 and 22. This is going to fuse the BCR and ABL gene. BCR and ABL, they're going to fuse. Now, ABL is a tyrosine kinase, and that causes growth. That causes the tumor to grow and grow and grow and grow and grow. Yeah, so this is the reason it's a tumor. The Philadelphia chromosome, the BCR-ABL translocation. Yep, because it's going to fuse it into the on position. So let me put that here. BCR gene goes next to the ABL gene. ABL is a tyrosine kinase. So when BCR fuses with ABL, ABL gets turned on. Tyrosine kinase is turned on, you grow and 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 you grow. Now, this is important because we have a new drug that's going to block this. Well, it's not so new, but it's very testable. The drug that's going to block this is a tyrosine kinase inhibitor called imatinib. Gleevec, imatinib. Yep, it's going to block this beautifully. So that's going to be our drug of choice. Okay, so the best test is looking for the BCR-ABL, the Philadelphia chromosome. Use PCR. PCR, you'll find it. Best test. The best treatment is a tyrosine inhibitor, tyrosine kinase inhibitor, imatinib. Okay, so it all comes down to Philadelphia chromosome. Now, what if your CML doesn't have this? Oh, poor prognosis. Okay, so a small percentage don't have it. If it's negative, well, then all I can do is a bone marrow transplant. That's it, bone marrow transplant. They don't do so good. So if you got the Philadelphia chromosome, good prognosis because I can block it. If you don't have the Philadelphia chromosome, I got to do a bone marrow transplant. Right? Good. All right, now, presentation. They're going to come on with a slow onset of white counts that slowly go up and up and up, and their spleen gets bigger and bigger and bigger because all the white cells get sequestered in the spleen. So this is a leukemia with a very big spleen. So white counts really high and they'll have a big spleen. Now they often get fatigue, night sweats, and fever. Now wait a second. Night sweats, fever, and weight loss. Can anybody tell me what that's called when you have night sweats, fever, and weight loss? B symptoms, constitutional symptoms. Now the board likes to throw that in because if your white count is high with neutrophils and you got fever and night sweats, it looks like an infection. It's going to look like an infection because the white count is high with neutrophils and you got fever, night sweats, and some weight loss. It looks like an infection. Okay? All right, so it's very important. Now, they often have a lot of abdominal discomfort because they got the biggest spleen you'll ever see. This spleen is so big it pushes on the diaphragm, pushes on your stomach. You feel like there's a mass in there, like a dragging sensation, something to hold you down. You got a football-sized spleen. Now, the tumor cells can also infiltrate the bone. You can get some bone pain. And sometimes you get large nodes. But I want you to remember, which kind of tumor is going to give you nodes? A myelogenous leukemia or a lymphocytic leukemia? Which one's more likely to give you big nodes? Lymphocytic leukemias. Much more likely to give you big nodes. Okay? This usually gives you a big spleen. Nodes, not so much. Good. All right, now, infections can occur here and bleeding can occur here because these white cells usually maintain their function, but not completely. Not completely. So they can get increased infections and bleeding. Now, very important for CML. The white counts here are often over 100,000. So it's not uncommon for them to come in with white counts that are like 3, 4, 5,000. That's incredibly high. Remember, the normal white count is up to 11,000. 11,000. This is out of control. So these patients are going to get shortness of breath because in the lungs, it's in the eyes, you can't see, it's in your penis, you get priapism, you're getting stroke, leukostasis. You need to do leukapheresis on the double here. Leukapheresis, middle of the night. Yeah, leukapheresis. I mean, usually it's in this area, like 300, 400,000. Every patient's different. But typically, usually I see it in the 400,000. I mean, really high count, somewhere in this range. That's when we see leukostasis, and every patient's different. Leukapheresis on the double. Okay. All right. So when it gets really high counts like this, that's super high. You're going to worry about leukostasis and leukapheresis. All right, now the count in the white cells are increased, and as I mentioned, it's mostly neutrophils with bands, so it looks like a left shift. Now, very important, these are tumor cells. They don't have the enzymes they're supposed to. So a very important clue is check the leukocyte alkaline phosphatase level, the score. LAP score. In these patients, it should be high. It's low because they're tumor cells. So this is basically your first test. First test I'm going to do when I see lots and lots of neutrophils, I'm going to do an LAP. It's quick, it's easy. Do the LAP stain and you will see that it's low. Now, if this was an infection, it would have been high. This is a marker of immaturity. So when it's low, it's immature, it's really a tumor cell. Now, the confirmatory test is BCR-ABL, looking for the filled chromosome. Now, another important point is when you have a bacterial infection, you don't usually have basophilia. But in this disease, they tend to have very high basophils. Eosinophils are up as well because all of the cells are proliferating. Myeloproliferative. All cells are proliferating. Okay? What would you like me to repeat? The LAP? LAP? Okay, remember, when a patient comes in with a high count and fever and night sweats, I'm thinking it's a bacterial infection. Now, number one, the white count here is really high. Over 100,000, that's usually leukemia. Then I will test it with the leukocyte alkaline phosphatase score. Normally, neutrophils that are normal should have high enzymes. Neutrophils should have enzymes because they're killers. It should be high. If it's a tumor, tumors don't listen. Tumors have low enzyme. They're immature. They don't have the enzyme they're supposed to. So if LAP is low, that tells me the answer is going to be CML. To confirm it, look for BCR-ABL. To confirm it, look for BCR-ABL. Basophilia will be increased because it's myeloproliferative. Basophils are up, eosinophils are up, red cells are up, platelets are up, everything's up. Okay. The treatment of choice for leukostasis is leukapheresis because it works right away. Hydroxyurea can also be used, but it takes longer. Got it? That's how you're going to treat it. Now, ultimately, treat the tumor. But treating the tumor takes time. Get the countdown right now, hook them up to a apheresis, spin it, throw in the trash. Okay? Good. All right. Now, question. B12 is often elevated because it's an acute phase reactant. B12 is often elevated. Just interesting finding. But really, here's what I'm looking for. Philadelphia chromosome. So we can fish it on a karyotype. So here's the fish. Okay. It's kind of really hard to see what's going on here. But I think you can see these two genes are put next to each other. You got two different colors here. That's BCR and ABL going together. They should be separate. They shouldn't be next to each other. But you see this like kind of orange and a green next to each other? They should be separate. They're put together. That's the Philadelphia chromosome. BCR is put next to ABL. But usually we don't fish it anymore. We do PCR. Take your blood, do PCR, look for BCR ABL. Okay? This is the gold standard. This is your confirmatory, most accurate Philadelphia chromosome. You can do a fish of a karyotype, but PCR looking for BCR ABL is even better. That's usually what we do. Take your blood, do PCR, looking for a BCR ABL translocation. Now, as I mentioned, Basophils are up, red cells are up, and platelets are up too. It's myeloproliferative. Everything's up. All right, now, drug of choice is imatinib, also known as Gleevec. This is your first line. This is the first line ever. Now, after they invented it, well, some people got resistance. So if they get resistance to this, then we go to the second generation tinibs. The second generation are these guys, second generation. So we always start with imatinib. If it doesn't respond, then we go to the second line drugs. Okay, so second line, these are just tinibs. They're just tinibs that are slightly different, but they do the same thing. They block the Philadelphia chromosome. So this is your best initial therapy, and these are direct inhibitors of the tyrosine kinase that was made from the Philadelphia chromosome translocation. Look at this, all about a 90% hematologic response. So most people respond. They respond beautifully. And 60 to 70%, I can't find the Philadelphia chromosome. Gone, completely gone. Now the good news is the milder your disease was when you started, the better the response. The higher your counts were, the less the response. Okay, so it seems to correspond with how bad you were when you started. Generic names are always asked. Generic names are always asked. The treatment is imatinib. Imatinib, first line drug. Now, if it doesn't respond, use the second generation ones. Yeah, these came up next. All right, so these are second generation. They work the same way. They're tyrosine kinase inhibitors. They're tinibs. All right, now what if that fails? What if it doesn't respond? Well, if it doesn't respond to any of the tinibs, then you go to bone marrow. See, when I was in med school, we didn't have tinibs. We didn't have it. So all we used to do was bone marrow, and these patients did very poorly. Bone marrow works, but it's not great. It's not great. So we used to do bone marrow as the first line. Not anymore. It's no longer first line. First line is the tinibs. Tinibs, 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 tinibs. If the tinibs fail, then you do bone marrow. And again, bone marrow is not so great here. It doesn't work as great as you'd like it to. All right, feel good? So we got acute leukemias done, very aggressive tumors. Then we did CML with the Philadelphia chromosome, the big spleen, all the cells proliferating, the B symptoms. Okay? All right, now we got to change gears and do another chronic leukemia, but this time it's a lymphocytic leukemia. More likely to have big lymph nodes, right? Lymphocytes like lymph nodes. Good. So we call this CLL. This is the one that occurs in older people. So this is usually like 60-year-olds. CML was like midlife, 40s, 50s, up to about 60s. This is going to be around 60. These are older people. All right, now by definition, this is overproduction of mature, there's still tumor, but at least they're acting mature, lymphocytes. Too many lymphocytes. Yeah, it's usually B cells, usually B lymphocytes. Now the etiology, we don't know. We don't know why you get this. We have no idea why. Okay, no Philadelphia chromosome here. We just don't know why. All right, now it's asymptomatic in many cases. So how do I find it? You come in for your yearly physical. Everybody gets a CBC. The white count is elevated. Now, when the white count is high, I want the differential. We're going to find that most of the cells are lymphocytes. The lymphocytes have taken over. That's how we'll pick it up. All lymphocytes. Now, wait a second. What infection gives me a lymphocytosis? What infection gives me a lymphocytosis? Oh, virus. So we always have to tell, is this an old guy with a virus? Or is this an old guy with a tumor that looks like lymphocytes? So we got to figure out, is it a virus or fungal? Is it mono? Was the old guy kissing? Did he get mono? So we got to figure out, is this a tumor? Or is this just a lymphocytic response to a virus or fungus? All right, now most cases, as I mentioned, are over age 50. So on average, it's around 60 and up. That's usually when you see this. Now symptoms, non-specific. You come in slow with, I don't feel good. I don't feel good. I'm tired. I'm lethargic. Now, sometimes they come in because of big nodes. Remember, it's a leukemia, but sometimes it goes in the nodes too. So you can have some enlargement of some of the nodes. Okay, so that's another way it could present with big nodes. All right, now since it's a lymphocyte, it loves to go into the spleen. It loves to go into the liver. And sometimes it'll go in the bone marrow too. Okay? All right, now infection and bleeding, not common because these are mature cells. But what is important is these cells may not make immunoglobulins properly because they're tumor cells. So sometimes you have low immunoglobulins. If you do, IgGs are low, then you're going to get infections. Okay, because tumor cells, even though they're lymphocytes, they're not completely mature. They may not make IgG. In those cases, infections will occur. All right, now CLL can cause an autoimmune phenomenon because the tumor cell may make antibodies against you. What? Yep, the tumor cell is a lymphocyte. So he says, I'm not making normal antibodies. No, I'm going to make antibodies against you. I'm going to make antibodies against your platelets, or I'm going to make antibodies against your red cells. Huh, interesting. So question, if you get an autoimmune hemolytic anemia, what tests will confirm that there's antibodies on my red cells? What test is going to confirm that? Direct Coombs will be positive. Direct Coombs. Excellent. You guys learned from yesterday. There'll be spherocytes in the blood. Spherocyte in the blood. Direct Coombs positive. Excellent. Now we give this a fancy name. What's the fancy name? You don't need to know this for the exam, but what's the fancy name when CLL makes antibodies against your platelets and your red cells? They call it Evans syndrome. Evans syndrome. Good job, Jose. We call it Evans syndrome. Again, that's not something they're going to test. But as a doctor, you might want to know they call it Evans syndrome. Okay, for the exam, just know CLL can give you anemia. CLL could make antibodies and give you thrombocytopenia too. Okay, Evans syndrome. All right, now staging. Here's what I need to know. Most cases are low stage. They're low stage. Either they just have a high lymphocyte count, or they may have some big nodes. That's what most cases have. Sometimes they'll have a big spleen too. But these are pretty low stage. They have a great prognosis. They do amazing. Now, higher stage is worse. That's when you get anemia and thrombocytopenia. So this has a very bad prognosis when you get these symptoms. So here's the key. If it's low stage, we don't treat you. We don't treat you. We just watch you. We just watch you. When you have high stage, we're going to need to treat because their prognosis is not good. Let me show you what I mean. If you're low stage, the average survival without treatment is a decade on average. A decade. Now remember, if you're 65, how long are you going to live? Maybe a decade, even without the tumor, right? If you're, yeah. So we don't treat. Low stage, we don't treat unless there's some bad symptoms. We don't treat it. It's indolent. The rule is you're old. You're going to die with it, not because of it. You die with it. You die of something else. So again, this is an indolent tumor in the elderly. So usually if it's low stage, we don't treat it. Now, that's not true if it's high stage. You got anemia and thrombocytopenia, you're not doing well. So this is when we're going to add treatment. We're going to add treatment when there's anemia and thrombocytopenia because without treatment, they don't do well. So this is the ones we're going to treat. The ones with higher stage. Just remember, anemia and thrombocytopenia are high stage. That's when we need to add the treatment. Okay, now first we got to do the diagnosis, then we'll talk about the treatment. All right, now we're going to think about this when an older patient comes in and the white count is high and it's all lymphocytes on the differential. When I get the diff, it's like all lymphocytes. Look at that, 80 to 90% lymphocytes. Holy heck. So the white count is like 30,000. And it's all lymphocytes. Wow. So either this guy has got mono or some viral or fungal infection, or they got a tumor. Now, these are B cells. So the B cell markers like CD19 and CD20 are going to be positive. Okay, so to confirm this diagnosis, we're getting flow cytometry. Look for CD19, CD20, those are B numbers. But how do we know it's a tumor? Because it went crazy and got a T number too. It got a T number. It got CD5. That's how you know these are tumor cells. It got CD5 positivity. That's a T number. What's a B cell tumor doing with a T cell number? So again, it's got the B numbers, 19 and 20, but it also got the T number. That's a tumor. That's a tumor. So this is your diagnostic test. Flow cytometry, looking for B numbers and just one T number, CD5. Okay? All right, let's Natasha wants me to go through the algorithm. Old guy comes in. He says, I don't feel good. Okay, let's get a chem panel and a CBC. Everyone gets a chem panel and CBC. Everyone. When I do the CBC, the white count is through the roof. It's like 30,000, 40,000. Oh, maybe this guy's got an infection. Let me do the differential. So when I do the CBC with diff, I will see it's all lymphocytes. Oh, okay. Now, one clue they may give me is when I look at the smear, I'll see they look like lymphocytes. Just too many of them. Okay? But some of them will rupture. They'll smudge. Normal cells shouldn't rupture. If they start rupturing, maybe it's not an infection. So then I'll do flow cytometry. Do flow cytometry, I'll find B numbers and T numbers, most accurate confirmatory diagnostic, confirmatory accurate test. Got it. That's how we're going to make the diagnosis. So smudge cell, good clue, not diagnostic. What's diagnostic is flow cytometry. That's how it goes. And again, if the white count is 100,000, it's leukemia. You're going to go right to flow cytometry. The white count's 30,000, well, that could still be an infection. That could be an infection. Okay, so we'll look for some smudge cells, and if we don't see any evidence of infection, we will do the flow cytometry. Okay, excellent. Now, I want you to look at these cells for a second. Compare this cell to the red cell. Now, is this cell bigger than the red cell? Yes. But is it twice the size like the blast was? Is it twice the size? Is this twice the size of this? I don't think so. These are lymphocytes. They're not blasts. Blasts were so big you could have put 3 of the red cells in it. This maybe only 1, maybe 1.5. And so this would fit in there, but you wouldn't be able to fit much more. Make sense? Okay. What I said about the white count is, if I ever tell you white count over 100,000, it's leukemia. You don't get infections with white count over 100,000. So whenever you see white counts over 100,000, we know it's leukemia. We know it is. It ain't an infection. You don't get infections with white counts of 100,000 ever. We know it's leukemia, so we'll go right to flow cytometry to confirm that it's a lymphocytic leukemia. Okay, so we'll do 19 and 20, that's B numbers, and then find that crazy T number. It's crazy, it's a tumor, it's got a T number. It's a B cell that went crazy. All right, now we're almost to a break, but let me just finish this. For treatment, for early low stage with just the elevated white count or enlargement of lymph nodes, we don't treat. We say we're going to follow you. Enjoy your life. You're old, keep going to enjoy your happy hours, enjoy your walks. We're going to follow you. We're going to watch and wait and watch, because a lot of times when you're old, you may die of something else because you got a decade or so to live with this tumor. Now, if there is symptoms, we're going to treat. If there's symptoms, you're going to treat. Anemia, you got to treat that. Thrombocytopenia, you got to treat that. So high stage, which means anemia and thrombocytopenia, must be treated. So when you have these higher stage, we're going to use a drug called fludarabine. Now, before we had this drug, We used to use chlorambucil. That's what we used to use, but that's no longer the drug of choice. DOC is fludarabine. Boom, 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 boom. Fludarabine. So this is the drug of choice we're going to use for these patients with higher symptoms, anemia and thrombocytopenia. Okay? Okay, on these cells, these tumor cells, they got B numbers and T numbers on the same cell. That's why they're a tumor. That's why they're a tumor. Got it? That's why they're a tumor, because they got B numbers and T numbers on the same cell. Okay? CD1920 are B numbers. CD5 is a T number. Your lymphocytes should never have both numbers. If they have both numbers, they're a tumor cell. Okay? So it's like a B cell that went crazy. It's got B numbers and it got a T number. All right, okay, fludarabine is your drug of choice. Now, if they can't take it for some reason, chlorambucil would be the backup. But fludarabine for the US Army, fludarabine. Now, very important. If there is an autoimmune hemolysis, if there's Evans syndrome, what do I do for autoimmune diseases? Yeah. So if there's Evans syndrome, prednisone will help, right? Autoimmune, prednisone. And then one more thing. If the CD20 is positive, we have a monoclonal antibody against CD20 called rituximab. Okay, so if it's got CD20 positive, you can add rituximab to the fludarabine. Got it? So only if it's CD20 positive. Okay, usually they're 19 and 20. Okay, so if 20 is positive, you can use it. Okay, and that's going to help. But I can only use it if it's got the CD20 on the tumor cells. Rituximab. All right, good. So 3 drugs you have to know. That's it. Drug of choice, fludarabine. You're going to add prednisone for autoimmune phenomena, and you can add rituximab if it's got CD20. Okay, so these are additional drugs that could be added. All right, we did it. So let's take a well-deserved break. And any questions you have, I'll answer the break. I saw a lot of questions going through, so if I missed your question, let me know, because I want to support you guys completely. Okay, so we'll take a break. During the break, you can ask me any questions you want. All right, so think of them, throw them up during the break, and I'll try to answer them for you. All right, see you guys in a little bit. Okay, welcome back. Great questions. I love all these questions. So much fun. All right, so far so good. We are cooking with fire. Now we're doing the neoplastic lesions here, leukemias, lymphomas. We started with the algorithm. We're going through leukemias, we'll do lymphomas, doing them one at a time. We did acute, we did chronic. Now we got one more chronic one to go, which is hairy cell leukemia. It's kind of cool. It's the hairiest leukemia ever. Hairy cell leukemia. So when I look at these cells, they're lymphocytes. Look, the nucleus is bigger than the red cell. It's not twice the size. So these are lymphocytes, but they're really fuzzy at the edges. Kind of fuzzy. Not the best picture, but I think you can see little projections here. They call these, oh, this one's good, little cytoplasmic projections off this lymphocyte. That's a hairy lymphocyte. Lymphocyte with cytoplasmic projections. Now, who gets this? It's usually middle-aged, 30 to 60, and it tends to be men more than women, because even men's cells can be hairy. Now, how do they present? Well, they usually present with a pancytopenia. They basically clog up the marrow, and they don't come out. They're hard to find. So it presents with a pancytopenia and a big spleen. So it hides in the marrow, it hides in the spleen. So now I got two leukemias with a big spleen. CML had a big spleen, but it also had a high white count. Now I got hairy cell with a big spleen, but it's got a low white count. Doesn't want to be found, it's hiding. It's a hairy cell, it's hiding. All right, now they tend to have, when you aspirate them, a dry tap. Dry tap. When you try to suck them out, they don't want to come out. They hold on. The hair holds on. They hold on. Don't let me out. When you suck them out, they don't come out. So I want you to remember, dry tap with a pancytopenia. Dry tap, big spleen, pancytopenia. That's classic. Dry tap, big spleen, pancytopenia. Now, one more thing usually does this. What usually does this is myelofibrosis. When I have myelofibrosis, I'll have a dry tap, I'll have a pancytopenia, and then the spleen gets big because that's where the bone marrow cells go. We call that extramedullary hematopoiesis. So that's what's on the big differential here. When I see a big spleen, dry tap, and pancytopenia. Got to compare it to myelofibrosis. Now you'll tell them apart right away on the biopsy of the marrow. The aspirate is dry, but when you biopsy the marrow, you'll see it's full of tumor, just packed with tumor cells. So that'll differentiate it from myelofibrosis for sure. All right, now the best initial test is to look at the smear and see the hairy cells and confirm it usually with the trap stain. Trap stain. Trap the hairy beast. Trap the hairy beast. Or if you're a Star Wars fan, Admiral Aardvark. I can't even say it. I can't talk today. I'm getting my voice back, but I'm losing my mind. Admiral Akbar. Admiral Akbar. It's a trap. It's a trap. It's a trap. There's hairy cytoplasmic projections. It's a trap. All right, I'm trying. So the best initial test is when your count is low, you get a blood smear, CBC with blood smear. You see all these hairy lymphocytes, and then you confirm it by doing the trap. Trap the hairy beast. Trap the hairy beast. That's the best initial test. Now, how am I going to confirm it? Flow cytometry. Wow. Okay, so flow cytometry was the best test for CLL. Flow cytometry was one of the best tests for differentiating acute leukemia from chronic leukemia, right? So very important flow cytometry when it comes to leukemias. Very important. Now, what am I going to look for in flow cytometry? Well, number one, it's a B cell. So I'm going to look for CD19 and CD20. CD19. Let me type this. It'll be quicker. Go look for CD19 and CD20. B numbers. Yeah, but lots of tumors have that. You want to look for specific markers. We want to look for CD11C, CD103, and CD25 positivity. These are the numbers we want to look for. So 11C, 103, and 25. Look for these markers. Now I'm giving you all three because I don't know which one they're going to put on your exam. They're going to put the one you don't know. So know all three. So 11C, 103, or CD25. Those are the numbers that are usually positive. Now for the exams, they like 103. Maria's like, they like 103. Okay? But sometimes they do 11C as well. Okay? So know them all and they can't get you. Can't get you. So I got the trap stain was the initial. The confirmatory is CD numbers by flow cytometry. It's a B cell who has CD11C, CD103, CD25. Look for one of those markers. All right, now how do we treat it? Well, two things we're going to do. Two things. Number one, cladribine. Cladribine. This is your DOC. Cladribine, or you can use pentostatin. Either one. Either one. My hospital, we lose cladribine, but either one. Now these both work the same way. These are drugs that inhibit the enzyme adenosine deaminase. Adenosine deaminase. They're going to inhibit that enzyme in the hairy cell. Okay? So whenever you give cladribine, it inhibits adenosine deaminase in the hairy cell. It inhibits that enzyme. Now what's going to accumulate? Deoxyadenosine. Deoxyadenosine accumulates and the hairy cell dies. Got it? So that's how both of these drugs work. They're adenosine deaminase inhibitors. That's what they are. Adenosine deaminase inhibitors. Now the second drug I want you to add here, if it's got CD20, can anybody tell me what drug you want to add? Can anybody tell me what drug you want to add? Rituximab. You want to add rituximab. So the treatment in my institution is cladribine plus rituximab. My tongue. Cladribine plus rituximab. That's how we treat this. Okay, cladribine plus rituximab. Okay, it's only if it's CD20 positive though. It's got to be CD20 positive. All right, now there was a question. The question was, what does TRAP stand for? Oh my goodness, I didn't tell you. TRAP stands for tartrate-resistant acid phosphatase. Tartrate-resistant acid phosphatase. That's what TRAP stands for. Okay, so stain them and see if they're positive for tartrate-resistant acid phosphatase. If that's positive, that's a great screening test. Then confirm it with flow cytometry. Another question was, isn't this drug cladribine going to inhibit your bone marrow? It will if you give high doses. Sure, all drugs hurt you too. But remember, the most rapidly dividing cell will pick it up the most. So it's going to hurt the tumor more than it hurts us. Hurts the tumor more than us. Okay, so yes, cladribine will be toxic if I gave too much, but luckily the hairy cell dies before we do. Excellent, excellent. All right, so for only one page, there's a lot of points here. Oh, what accumulates when I give adenosine deaminase? Well, deoxyadenosine. Think about that. Adenosine deaminase is inhibited. Deoxyadenosine accumulates. Deoxyadenosine accumulates. Adenosine, deoxyadenosine, right? Makes sense. That's what the enzyme's supposed to do. Deaminate adenosine. Good. All right, I think we got that one covered. Now, what was the pre-leukemic syndrome? It was called myelodysplasia. It's basically dysplasia of your marrow. So this is a pre-leukemic disorder, and if you live long enough, a lot of people will go on to develop acute leukemia. Now, most commonly AML. Most commonly AML. So a percentage of people will live long enough to go on to acute leukemia. Now, a lot of cases are due to mutations, especially in the 5q area. And these are going to be very special because we're going to add a special treatment for this one. Okay, so very important to look for the genetics. Always look for the genetics to see what kind of mutation is present. Okay, so when you got the 5q deletion syndrome, we're going to add something special. All right, now in general, myelodysplasia tends to occur in older people, and they'll come in with a pancytopenia. They tend to have an elevated MCV. So what are you thinking of when I say elevated MCV? Anemia with elevated MCV. Anemia with elevated MCV. You want to think of macrocytic. So you want to think of what kind of you want to think of B12. You're going to think of B12. So we're going to have to make sure there's not B12 deficiency or folate, B12 and folate. In addition, they're going to have fatigue from the anemia. They're going to have infections. They're going to have bleeding. They're going to have a pancytopenia. All the cells are low because the marrow's dysplastic. Yeah, it's not responding properly. All right, now, how many blasts do I have? It depends. It depends. Everybody will be different. But the key is, over time, the blast percentage goes up and up and up and up until you get to over 20. Once you're over 20, you have acute leukemia, you have AML. You have AML. Okay? So basically, you always look at the blast count because it tells you how close you are to getting leukemia. The higher the number, the closer you are to getting leukemia. Now, interesting, not every patient gets leukemia because a lot of the patients will die from infections or from bleeding, from the pancytopenia, before they get acute leukemia. Isn't that bad? That stinks. So you have pre-leukemia, but you die even before you get leukemia. So this is not, we don't like dysplasia of marrows. We like our bone marrow. Now, why must I exclude B12 and folate? Because they get anemia that's macrocytic. They tend to get big cells. So we always have to look at the neutrophils and see if they're hypersegmented. Au contraire. B12 and folate, hypersegmented. What do you see in myelodysplasia? Hyposegmentation. Look at this neutrophil. How many segments do you see in this neutrophil? I see one segment. I see a second segment. In fact, it looks like sunglasses, doesn't it? A bilobe neutrophil looks like sunglasses. We give this a fancy name. We call this the Pelger-Hewitt abnormality. It's a neutrophil that only has 2 segments. Remember, they're supposed to have 3 to 5. It's supposed to have 3 to 5. It only has 2. Looks like a sunglasses. We call this the Pelger-Hewitt. See, this is telling me the bone marrow is dysplastic. It's dysplasia. It's pumping out funny-looking neutrophils. It'll also pump out red cells that are nucleated. You get nucleated red cells. It pumps out funny stuff. Now remember, always check for the 5q deletion because we're going to add a very special drug for that. We're going to use lenalidomide. So for 5q deletion, we're going to add a special drug, which is an analog of thalidomide. It's called lenalidomide. So very important you look for the 5q deletion cases. All right. Now for treatment, because they have anemia and we're all going to transfuse them. Transfuse them red cells, transfuse them platelets. Their bone marrow's not working, so we transfuse them. And of course, if they get infections, we will treat the infections as well. Now, how am I going to stimulate the marrow to work a little better? We often give erythropoietin to try to stimulate the marrow to make the anemia better. Okay, so transfusions plus or minus erythropoietin to try to help with the anemia. Now, some disease-specific therapy. What are we going to use for myelodysplasia? Well, one of the drugs that we like to use is azacitidine. It's one of the drugs we can use. But the one I want you to remember for an exam purpose is we're going to use lenalidomide when 5q deletion is present. Lenalidomide is related to thalidomide. Do you remember thalidomide? Remember thalidomide, the one that gave you birth defects? Gave you little flippers instead of extremities? Yeah, thalidomide. This is related. It's like its cousin. So it's called lenalidomide, one of those thalidomide drugs. And listen, in medicine, there's only 2 times you're going to use thalidomide and its analog. 2 times. Myeloma and myelodysplasia. Myeloma and myelodysplasia. 2 times you're going to use lenalidomide or thalidomide. 2 times. Okay? And again, we use this only for myelodysplasia with the 5q deletion. When you have that deletion, when that's present, you're missing it, that's when you're going to give it. Okay? Good. Yeah, for any high-risk cases, we're going to add this drug. And this drug is usually used when you have 5q deletion. Update the book. Update the book. Okay? So let me repeat. High-risk cases, people are really doing very poorly, high blast counts, that's when we use this drug. High blast counts, the patient's not doing well, we'll use this drug. Then we'll add this drug. This drug seems to work when you got the 5q deletion on board. That's when we use this drug. Okay? Got it? All right, so again, thalidomide not used much. Only time we use it is myeloma and myelodysplasia. All right, so far so good. All right, only possible cure. If they ask me what is the only possible cure here, a bone marrow. Remember, their marrow is dysplastic. They're on their way to cancer. Your only chance of cure is if I can get a marrow match and do a bone marrow transplant. This is only going to be in young patients. Older patients don't do well. So bone marrow can be done in younger patients. Okay, good. All right, now let's move to the myeloproliferative syndromes. We already did one of them. We already did CML. That was a myeloproliferative. Remember, all the cells are proliferating? Same thing for polycythemia vera. All the cells are proliferating, but it's mostly red cells. Question, will the platelets be up? Will the neutrophils be up? Will the basophils be up? But the red cells are proliferating the most. The red cells are proliferating the most. So again, this is part of the myeloproliferative syndromes where everything is proliferating. But the red cells are proliferating the most. That's the key. So you're making excessive amounts of red cells. Now question, what if I go to high altitude? If I go to high altitude where there's not a lot of oxygen, well then my body will make more blood. You'll get high EPO and you'll make more blood, right? So this is increase in red cells without evidence of hypoxia or erythropoietin. This is a tumor. It doesn't need EPO. Doesn't need EPO, okay? This is going to have low EPO because tumors don't need EPO. Got it? So very important you recognize that the red cells are increased, but it's not because of hypoxia. It's not because of high erythropoietin. In fact, erythropoietin will be low. So let me repeat one more time. Red cells are high. How do I know? Hemoglobin is high and your hematocrit is high. A lot of blood. There's sky high. But the EPO is low. It's not going to be high because the EPO is high. Now, this is not physiologic. This is a tumor. It's a tumor of your marrow. All right, now it's going to present with a really high hematocrit, usually in the 60s. 60% blood. Wow! You're going to get hyperviscosity. Exactly. Very high counts. Now, often they get big spleens because they sequester a lot of the red cells. Now, as I mentioned, all cells are increased, so don't be surprised when the platelets are up a little bit, white cells are up a little bit, basophils are up a little bit. They're all increased. But this is important. Because of the hyperviscosity, one of the biggest problems they're going to have is thrombosis. That's a major cause of morbidity. That's a major cause of mortality. So much blood, you get hyperviscosity, you're going to thrombose. Now, clinically, what do they have? They tend to be very red and swollen. They're congested, too much blood. So plethora means you're red and swollen, especially in the face. So you're very red, you're very full face. Now, as Avni says, there's basophilia. So if you take a hot shower, hot bath, the basophils will release all of their histamine and you'll get itching. That is a board favorite presenting finding. Itching, pruritus. I'm trying to write pruritus. I'll never be able to write it. Pruritus. I'll run out of room. So just put itching and hot showers. Itching and hot showers. Itching and hot showers, big clue. Big clue. So again, too much blood. You come in very congested. You look red, you look red, you look red. If you take a hot shower, you get itching, and you're at risk for thrombosis big time. That's polycythemia vera. All right, now again, the key here was the high hematocrit without any reason. There's no hypoxia, there's no carbon monoxide poisoning, there's no EPO. EPO's low. Now, why is this growing if there's no EPO? Well, do you guys remember? Here's the cell. To make a cell grow, you give EPO, erythropoietin. So here's the EPO receptor, erythropoietin receptor. So to make this cell grow, I'm going to give it EPO. EPO binds to its receptor. How does the receptor bring the signal in? How does it bring it in? Well, it's going to work with JAK2. JAK2 is a tyrosine kinase, and it will turn on STAT, the STAT pathway, JAK-STAT. Now, STAT is a transcription factor. STAT will go into the DNA and cause the cell to divide and make more blood. It's a transcription factor. It goes into the DNA and turns on cell division and growth. That's how this cell will grow. All right, now the majority of cases of P. vera have a mutation in JAK2. They mutate it so it's always on. Tyrosine kinase on. So the most specific test is to look for this Janus kinase, which is Janus kinase, JAK2 mutations. It's turned on. So now you don't need EPO. You don't need the EPO. Look, the signal transduction is already on. You don't need EPO. So EPO in this case will be low. Yet the cells still grow because of JAK2. So this is your specific confirmatory test. Specific. Look for the JAK2 mutation where you turn on JAK2. Now you get signal transduction and the bone marrow grows and grows and grows. Okay, that's signal transduction. JAK2. They call it the JAK-STAT pathway. All right, now how do I treat you if you have too much blood? Well, get rid of it. The treatment of choice is phlebotomy. Now, why would I add aspirin? To prevent thrombosis. So let's lower the blood, get rid of the viscosity, and give you some low-dose aspirin to prevent thrombosis, because that's the major cause of death here. That's the major problem, thrombosis. So phlebotomy and aspirin. Now, how much phlebotomy do I do? JAK2 is a tyrosine kinase. JAK2 works because it's a tyrosine kinase. So it gets mutated so it's on. All right, now question, how much phlebotomy do I do? I like it, Julieta. How much do I do? As much as the patient can tolerate? There you go. Rebecca's got it. We gotta have a target. We gotta get the hemoglobin down. The hematocrit's gotta come down. Because if you have a high hematocrit, you're gonna get stasis, right? You're gonna get stasis. So we're gonna do phlebotomy until your hematocrit is below 45. Then I will repeat it to keep it below 45. So if you come in next time and you're 44, no phlebotomy. Come in the next time and it's 50, phlebotomy. So I keep phlebotomizing you to keep your hematocrit under 45. So again, you're taking low-dose aspirin, and I keep doing phlebotomy as much as required to keep your hematocrit less than 45. Now question, if I keep taking your blood, I'm taking your iron. So what kind of anemia am I going to create from all this phlebotomy? Iron deficiency. Yep, I'm going to make you iron deficient here. I'm going to give you an iron deficiency anemia from all this phlebotomy. So the board question will be, patient with polycythemia is being phlebotomized. The doctor notices they developed iron deficiency anemia. Do I give them iron? Do I treat their iron deficiency anemia? We don't treat their iron deficiency anemia because that's a good thing. Iron deficiency anemia means they'll make less blood. They'll make less blood. That means the hematocrit will stay down. It's going to help us. It's going to keep the hematocrit down. You'll have to do less phlebotomy now. So that's actually good. And you tell them, dude, don't take any iron supplements. Dude, don't eat high iron food, because if you do, you'll make more blood. It makes sense? So iron deficiency is actually good here. Okay, we're not going to treat it. We're going to be happy when they have iron deficiency. Isn't that weird? We're happy when they have it because it'll slow down the need for transfusion or the need for a phlebotomy. That's good. All right, now other things I can do. If I can't tolerate phlebotomy, I don't have venous access. I was an IV drug abuser. I scarred all my veins. I live in the boondocks. I can't go get phlebotomy. It's a 60-hour drive. I can't do it. Well, if you can't do phlebotomy, then we can do hydroxyurea. Now, hydroxyurea is never going to cure you, but it will keep the counts low. Okay? So phlebotomy is your treatment of choice. But if it's not possible logistically or because of venous access issues, then you can do hydroxyurea instead. All right, now since the cells are turning over, you're at risk for a lot of uric acid production, and you could get gout. You can get gout. So when uric acid starts rising, you want to give something like allopurinol to inhibit xanthine oxidase, or rasburicase to break down uric acid. Okay, so these drugs are used because whenever cells are turning over rapidly, you get a lot of uric acid production. Now, one more thing I need to know. Itching. I got itching. What am I going to do if I have itching? Well, antihistamine, H2 blockers, right? Antihistamines. Makes sense. Okay, now one more correlation from step one. If they have a lot of basophils and they're releasing a lot of histamine, you're going to get itching, but what are you going to get in your stomach? What are you going to get in your stomach from all this histamine? Excellent. You guys are awesome. You're going to get peptic ulcer disease. So that's one association you should be aware of. Anybody with polycythemia who starts getting a lot of abdominal pain, probably a peptic ulcer. So start looking for peptic ulcer disease. And again, H2 blockers will be very helpful because it's all about the histamine here. Histamine. All right, I like it. Now the second myeloproliferation, actually it's a third one. CML was 1, P-Vera was 2. The third one is essential thrombocythemia. So again, all the cells are proliferating, but this time it's mostly platelets. It's the megakaryocytes and the platelets. So this is a form of myeloproliferative where the platelets are proliferating the most. So think about this. You're going to become a platelet millionaire. This is the one kind of millionaire you don't want to be. Because with 1 million platelets, 2 million platelets, 3 million platelets, you can have thrombosis, or they may not work because they're tumor cells and you might bleed to death. How stinky would that be? Oh, the patient just bled to death. What was his platelet count? 3 million. But they still bled to death. Well, that stinks. He had plenty of platelets, but he still died. Because they're tumor, they may not work. So again, the problem here is you become a millionaire, but a platelet millionaire. You get thrombose or bleed. Now, just like P-Vera, what is part of the signaling pathway for thrombopoietin? JAK-STAT. It's part of the thrombopoietin pathway too. So about 50% of patients are going to have JAK2 mutations where it's turned on. 50%. So for P-Vera, it was like 95%. Here it's about 50%. 50%. So again, a pretty good test, but only about half are going to have JAK2. Okay?